All right. Good morning, everybody. Today we're going to learn a career as about labor and delivery nurse. And before we start, let's do a check-in. As you know, you need to check in so that your teachers know that you're here. And if you have questions, this is a great questions document that you can reference to. And the evaluation form. This is how we give you attendance and a credit for attending this event. This is also a requirement for high school student in Oregon. If the QR code doesn't work, we'll have the bit.ly link on the chat. Be fully present, pay attention, and participate. Ask questions. Is a good time to ask questions. And again, submit your evaluation right after the event so everything is still fresh. And again, this is a requirement for you to graduate. And that is it for me. Let's have Lauren.
Hello, everybody. So I just want to say hello and ask sort of who's in the space with me, sort of maybe your ages or what level in school you are. I'm not sure if you want to put on your video or just answer, unmute yourself or put your answer in the chat.
Well, I can let you know. So we have a few schools, Hillsborough High School. Oh, there we go. We have a few in the chat.
Hello, Brooke. In Hillsborough High School. Not sure how many people are there. From Glencoe. Good to meet you, Brooke. Zia, I'm not sure I'm pronouncing that right. Senior at Glencoe. Excellent. All right. I really appreciate everybody coming. It's been a long time dream for me to be able to share a little bit back about my experience as a nurse. And okay, there we go, 17, 18-year-olds. And sort of help others come to a profession that I really love and care about deeply. Because if I hadn't been shared the experience from somebody else, I wouldn't be here. So I'm really glad that you guys are all here. I suppose, Catherine, we could move to the PowerPoint if you'd like.
Yeah, if you're ready, feel free to get started.
Okay. And then just want to see, I'll be sharing the screen properly. Can people see that?
Not yet.
So the green button at the bottom where it says share screen, click on that and you should get a pop-up of which screen you want to share and just click whichever has the PowerPoint. And then go ahead and click OK, I think it says.
All right.
Yes,
Some of us, perfect. Yeah, some of us have not been teachers, so we don't know. Okay, so I guess here we are. So just go ahead and move on to the first slide. So before I jump into my sort of history, I just thought I would bring up this image and sort of as a sort of warm-up activity for everybody. So I'm just going to bring you, imagine you're walking in through high school and you see this student, say she's a classmate of yours, and she's in the hallway and you see this scene. What are you noticing?
So it doesn't, right now, all I'm seeing is the labor and delivery, one nurse's journey, and then the PowerPoint editing.
Let's see, I'm sorry.
Okay, so I see it now, but I still see all the editing, if that's fine.
Okay. I'm not sure. Let's see. I wonder if that can be opened in a new tab. So sorry. 1 second.
So if you go back to the editing, I think you can hit slideshow up top as one of the tabs. It's like design, transitions, animations, and slideshow all the way to the right. That one. And then from the beginning over in the left corner.
Are you guys seeing that now?
I don't see it.
It's still loading.
Okay.
Let's see if I share this. Are we there?
There we go. Sorry. There we go.
And so hopefully it won't move on until I press it. Okay, so if we're all here, I just want to, so I'll start again here. So imagine you're in high school and you walk down the hallway and you see your classmate or friend in this scene. What are people noticing about this scene and or what's going on for this girl? You could unmute yourself or put something in the chat. Maybe Catherine, you can help me with people's comments. I'm not sure I can see.
Yeah. So in the comments, it says she looks lonely. She looks uncomfortable. They look uncomfortable. She seems sad.
Excellent. And what makes you notice that as their behavior? Are there any physical, like nonverbal cues that help you understand that?
They say holding her hands to her chest, body language and facial expressions, her folded arms, no eye contact, eyes down, hands and arms crossed.
Excellent. So using your powers of observation, that's the first tool of a nurse, is to walk into a room and read the room. What is going on? So without knowing exactly what's going on for this girl, what do you think could be helpful for her? What could you do to help in this scenario? And you can put your comments in the chat.
They're saying talk to her, make her feel comfortable, go ask if she's okay, ask if she needs anything, approach her.
Yeah, all of those things. So, so exactly. So talking to her, finding out what happened. If this situation is an unsafe situation, you could help escort her to another hallway, get her out of this hallway to another classroom, and sort of get her to a safe place where she can explain what's going on, and she can be safe. So exactly what you did, you assessed, and then you're going to do something about it. So that's going to be helpful. So that's being a nurse right there. So I'll move on to how I came to be a nurse. So it all started with a job shadow on a renal unit. Renal unit is a unit in the hospital that cares for people who are struggling with kidney problems. And I was helped to get on this job shadow by my mother, who worked at this hospital. And what I noticed that day, the nurse who was caring for this patient, she was looking through the chart, like this woman in the picture, and noticed that the patient's potassium level, which is a certain electrolyte, was awfully low. And that is life-threatening for renal patients because their kidneys cannot help manage their potassium levels. And this patient could have had a heart attack. And I was totally shocked. What do you mean? Like, this person could have had a heart attack? Well, what do we do? And she went and found the chart, and she noticed that the patient had a procedure a few days earlier, and his potassium supplement was not restarted. And so the potassium levels had gotten really low. She called the doctor, got the order, and in my view, saved that patient's life. And I was really surprised that the doctor didn't know, but they come on the floor once a day. And as the nurse, you're the eyes and ears of the physician, and noticing, like coming into the room, assessing, looking through the chart, and you're noticing what's going on, and you're often the first on the scene to detect a problem. And I thought, my goodness, that woman is a knight in shining armor. I want to do that. And so I chose a college that had a nursing degree and went straight through, entered when I was 18, came out when I was 22. And actually, when I first started nursing, I was really passionate about cancer care and the unique trajectory that, that happens when people are in cancer. And so I did that and did that for 3 years in Tacoma, Washington. And then I wanted to work internationally. And so I took an opportunity to work as a community health nurse, primary care nurse in Honduras, and worked in an NGO there with at a children's home. Did that for a year, and then I came back to Portland, did some outpatient cancer care, then inpatient cancer care again, and then eventually asked myself, where's the happiest place in this hospital? And came to mother baby unit and then labor and delivery. And I've been a nurse for 13 years and been doing mother baby labor and delivery for about 4 years. So that's my my history there. Any questions at this point?
Not yet.
So I just wanted to sort of bring up, what is it that a nurse is doing on a daily basis? So I walk on the floor, find out what my assignment is. And if I'm talking specifically a day where I'm working labor and delivery and not postpartum, then I come on, I have just usually one patient, find out their history and where they're at in their birth process and help them along. I'm giving meds, I'm assessing them, doing their vital signs, listening to heart and lungs, thinking about their medical conditions that they've had in the past, and then how that affects their care now, talking directly to my patient and their family members, say it's a partner, boyfriend, husband, finding out what their goals are and making a plan together so that they can have their goals met. So, and then these are a couple things I use, the blood pressure cuff and stethoscope, listening to people's heart and lungs, as I said, and also assessing the baby. And then these are, over on the far left is a hammer mallet. I use that to test reflexes for a patient, like on their knees and their elbow. And this tells me about how their nerves are working, if they have one of the rare labor and delivery illnesses called preeclampsia that can affect their nervous system. And so that's one way I check that. The measuring tape below is how we measure babies. That's how we find out their length and their head circumference and all that. The bulb syringe is something I use to help clear the baby's mouth of amniotic fluid and other fluids when they're born. So that's all of that. So how do I assist in labor? So mainly, so this is the part of my job where it becomes a little bit more like an engineer. I'm trying to help a baby come through the pelvis and using information that the patient tells me about what they're feeling and what's the assessment from, if the physician's done the check, where's their level of dilation, how far up or down is the baby, what kind of pain sensations is the mom feeling, and what is this monitor telling me? So on the left, you can see the nurse who is, there's some bands on the mom's belly, and those are monitors to read the baby's heart rate and how often the contractions are coming. And the nurses, as you can see, putting your hands right on the patient, right? You have monitors, but we often say, don't serve the monitors, serve the patient. So get your hands on the patient. That's where the information is going to best come. Your monitors may be wrong. What's happening with the patient is what's actually happening. So with your hand on the belly, you can feel the tension and how hard the contractions are. That tells you a lot about where they're at in their trajectory. And this patient has a medication pump there on the side. She may have the medicine Pitocin going, which is helping to increase the strength of her contractions and pushing her labor along. And then in the lower picture, the nurse is placing a peanut ball between the legs, and that's something we use to help open the birth canal. Basically, motion is lotion in labor. And so if we're changing positions and using balls and different props to help open the legs that can help the baby move through. And here's a few more pictures. So in the upper picture, the nurse is helping with the mom through her pain. This is often a position that we see when people get about halfway through their labor. They go and find something and they want to lean on it. Their body just folds over. And so you can use touch and massage and teaching the partner how to help compress the hips or press on the low back to help diminish the pain and the contractions. In the lower picture, the nurse is helping the mom into a position that is one of my favorites for pushing. It's called squat position, and she's got a squat bar there. Even with an epidural, this is totally possible. Depends on how strong the epidural is or how dense, how much strength the mother has in her legs. But I love to use this position for at least a little while to help use gravity to bring the baby down. And then that picture in the middle is showing how a baby enters the pelvic canal. And this is that engineering part. How do you get an object you cannot see through another object? The baby can do a 180-degree turn inside. So how do you move those two parts through and to allow labor to happen? And based on what the mother is saying, based on how the labor is progressing, tells you a lot about, is this a healthy process that's going well, or is there something else that we should be doing to address and make space for the baby to move through? So this is more postpartum. So after, which means after the birth, what do we do? So a nurse will listen to the baby's heart and lungs, do vital signs. You can see them measuring the temperature of the baby there. Babies are covered with a bit of a white cream that we call vernix, and it helps protect their skin. It's really natural, good lotion for them. So just to notice that in the picture. And then the nurse is helping to wrap the baby. A lot of what we do in postpartum is education. So if you like teaching, teaching skills to people, this is a great job for you. Because in this picture, she's showing how to swaddle a baby, how to wrap a baby so that they are comfortable. Babies love what reminds them of being inside the womb. So, so that wrapping helps the baby to feel comfortable. And then in the lower picture, this is International Baby Sign Language for I'm hungry. It looks often like touching the face, licking, and putting the hand in the mouth. And so you're teaching parents how to recognize those symptoms. We don't wait till babies are crying. That's like, you're not listening to me, right? By the time you're getting there. So how to recognize those early signs and put baby to rest. So there's that. A little bit more of afterbirth care. In this, let's see, start with the bottom right photo. The nurse there is helping the mom learn how to breastfeed. This is a skill that we teach the most, and probably the biggest thing that people are learning after delivery. So that's something I really enjoy teaching, and it's a really lovely process to be part of. In the top picture is showing jaundice. So what is jaundice? That is when a baby is born, their liver is not mature enough to process blood cells that have died, blood cells that are not functioning anymore. And instead of being excreted or moving out of their body through the baby's poo, which is what's going to happen eventually, it comes out in the skin instead. And so it gives the skin a yellow or orangey cast. And you can see in this baby's eyes, particularly the yellowness. And this is dangerous because it can cause lethargy like sleepiness, not wanting to eat, and even brain damage if left untreated. So in the bottom left picture, you can see the mother there with her baby who's receiving phototherapy, which is a way that we use light to help remove that jaundice from the skin directly. It's a pretty amazing tool that we have. So before I actually move on to that labor case study, any questions about my day? in labor and delivery or postpartum.
Yeah, so we have two questions. So one, you said your mom is a nurse. Is there anybody else in your family who's in medical care?
So my grandmother in 1940 went to nursing school and was a nurse. And then my mother became a nurse practitioner, which is like a nurse who has an advanced practice degree and can prescribe like a physician. And trying to think if there's others, but those are the main ones. Yes.
Okay, and then what's your favorite part of your job?
Ooh. So I love nursing in all forms. Labor and delivery and mother baby is what I'm doing now, and I'm really passionate about that. But I just love helping people meet their goals. And so whether that's in kidney care or cancer care or mother baby, you can help people meet their goals. I think I love best if I take care of the same patient over multiple days. I can see them move through from being pretty far away from their goals at the beginning. And then with every day as they learn better and better, how to be parents, say, or how to get out of bed after having a C-section, you see them get better. And it's just so exciting and fun to be a part of that.
And then what are some of the most common misconceptions about the job?
Let's see. I mean, I think that there's kind of a joke about mother baby that we just hold babies. But really, like if you're doing your job well, you're like teaching your parents how to hold their babies, right? We are pretty busy, so we don't have so much time to hold babies. Occasionally, especially on night shift, there may be a little bit more time where, say, if a family is just extremely struggling, we can take the baby out and then hold them in the nurse's station while the parents get some rest. But that's pretty rare. Usually we're busy working, running around to the different rooms, giving pain medication, helping with breastfeeding. So there can't always be somebody in the nurse's station to babysit. so we don't just hold babies. I think that's a question. And I think maybe another misconception is that our job may be just kind of just helping with pretty regular like vaginal deliveries and that there's not a whole lot of assistance required. But in my job, my view is pretty skewed. Working at OHSU, we're really high risk. So we are taking care of the sickest mothers in the state. And so there may be a lot of times the babies that we have are going to be born with genetic abnormalities, and we need a large NICU team there to take care of them. Or the mother may be coming to us with quite a lot of illnesses now that kids with cardiac diseases are able to survive their childhood and go to adulthood. They become adults and they have babies. And so then you have a mother who's coming to deliver who has a heart that does not work well. So then you have to think about how to modify her labor so that her heart doesn't give out in the middle of her labor, right? So we're caring for people with complex medical histories. We also do a lot of help for mothers with substance use disorder who may have been using methamphetamine or heroin throughout their pregnancy, or who had moved on to methadone, which is a medication to help prevent withdrawal during their pregnancy. And then you're helping to sort of prevent the amount of damage that can come from those substances.
Mm-hmm.
So it's quite complicated, but I like a variety.
Do you get to help deliver a baby every time you're on shift?
Probably every other time I'm on shift. Sometimes you help with all the early part of labor. I'd say a labor on average takes about a day and a half. So I may be coming in early, in the middle, not necessarily at the end. Sometimes I walk on shift and I walk into a room where a woman is pushing and I get to be there for the delivery, which is really fun, but I don't always get to.
And then what would you consider the hardest parts and the easiest parts of your job?
Easiest. I think relating to people is probably the easiest part for me, just getting in and becoming comfortable and finding out what people's needs are is probably on the easier side for me. One of the hardest things for me is if conflicts arise between nurses and physicians or other members of the team. Sometimes when things get really stressful or something's really unsafe that's going on between the mom, with the mom or the baby, tensions get high and everybody in the team is working towards the same thing. We all want a healthy, safe delivery for this mom, but we may have disagreements about the best way to do that. And so how to communicate in a way that is the least likely to make other people defensive, that's going to help you guys coordinate your ideas or come to an agreement between two different ways of doing things is probably the hardest task in our job.
And then do you also assist when a mom needs like an emergency C-section?
Yes. So labor and delivery nurses also work in the OR. So unlike other med surg, which is like kind of the regular hospital work, we also work in the operating room. So we have a couple suites, operating suites on the same floor with labor and delivery. And so if you see the heart rate monitor, say the heart rate monitor for the baby suddenly goes down and the baby's not recovering from a contraction and something looks bad, you got to get that patient to the operating room. And so it's a matter of quickly moving the bed out of the room, getting back to the OR, keeping really calm, talking to the patient, making sure we have consent, even in an emergency, that they understand what's happening. The number one way that you can reduce trauma is to give control back as much as possible to the mother. So even if something feels traumatic or scary, you can be reassuring that I'm going to stay with you. I'm right here. Your baby's going to be okay. Like, we're doing as much as we can, as quickly as we can. And helping the support people, right? The dad, the grandmother, the mom of the patient is there, reassuring them, telling them you can do everything as quickly as possible. And then making sure we have a clean and safe emergency delivery is also the role of the nurse.
Okay, and we still have a few more questions. I don't know if you want to continue with the presentation and answer these later, or do you want to just keep going?
I think maybe we'll do the case study and then we'll come back to questions.
Okay, sounds good.
So I'm gonna bring up a case study. Okay, so I'm just gonna read this out. So you enter your patient's room for morning report with the nurse. Inside, you see many doctors moving equipment around the room, and you notice a lot of noise, talking, and the voice of an interpreter phone. The patient, Melinda, and her husband are Spanish speaking only and are being consented for a C-section delivery. So you notice that picture there in the bottom. That's sort of some of what you might be seeing in the room. The night nurse explains to you that the baby's heart rate has looked bad on the monitor, leading to the possibility of delivering via C-section. However, since turning off the medicine to provoke labor, the baby's heart rate has improved somewhat. Unfortunately, the epidural placed earlier in the early hours of the morning has not been working. The night nurse tells you that Melinda has seemed afraid overnight and that the last time she gave birth was 10 years ago at her home in El Salvador. With each contraction, you notice Melinda, who is lying on her back in the bed, stirring painfully. The couple appear overwhelmed. So I'm gonna jump to this slide and then we'll come back to the case study. So how do we solve a problem in nursing? There's 5 steps that we use. First is assess, like you guys talked about with assessing the girl in the hallway. Diagnose, and that can just be like, what is happening? What's wrong? Plan, make a plan, right? Implement, start that plan, and evaluate. Come back with the patient and find out, did that work for you? What can I do differently? So let's go back. Can you say in the chat what seems to be what might be the first thing you want us work on? I guess, what are you, sorry, let's go back. What are you gonna, what do you assess first? What's happening in this room? And Catherine, you can just read out things as they come in.
So this says the mom is stressed, nervousness between like the Spanish speaking and the around Spanish, translation problems. There you go.
Yeah. So good eye, yeah, she's overwhelmed, scared. There's a language barrier. Great. So I'd say you can just say that those are your diagnosis. We have fear. Also, I'm going to notice that there's pain. Pain is huge, right? And it's really hard for her to stay focused on what's happening, like she's moving forward to C-section or to really give consent when she's in pain. So overwhelmed, pain, and then there's a language barrier. Great. So, so I'm going to make a plan. So first, what I, let's see. So actually, I'm going to give this back to you guys again. What, do you have any ideas about what you could do to help? First things.
Someone said go with her flow and her plan, but also make her feel comfortable.
Yeah, I really like that. So like, what is Melinda's goal here? What had she hoped for? And that's perfect. First thing. So I come in, introduce myself, and find out what does Melinda want and need right now. Other things?
Understand why the mom is nervous.
Definitely. So yeah, so find out why she's nervous, talk with her. So what I did when after shift change is talk with her, introduce myself. I speak Spanish, so we could get over that language barrier. If she was a Vietnamese speaking, any other language, I would get an interpreter and reduce the amount of action and stuff that's happening in the room. So can I, do all these people need to be here? If not, move them out, and we're just going to have a private conversation, me and Melinda and her husband. We're going to find out, why is she nervous? What's most important to her? And sounds like pain is really big. Maybe before we can even talk, I got to work on that pain. So I happen to be able to use fentanyl. I can okay with that with my physician, and we can reduce that pain right off the bat. Bring down those distractions. And then I noticed that she's flat on her back. I'm not sure how long she's been here. The baby's heart rate has not looked great, but it's getting a little bit better. I bet it would get a little bit better if I turn this patient. And also, it's not necessarily the most comfortable place. So, maybe this was done for a check, that's why she's on her back, but do we need to stay there necessarily? So asking her what position she wants to move to, would her side be more comfortable? And then, I found out after talking to her that she just is really nervous about the health of this baby. So I'm going to reassure her that the safety of her baby comes first, and tell her what I'm noticing that tells me that her baby is safe. So we looked at the monitor together, and I showed her the baby's heart rate that tells me that this baby is currently safe. So reassuring. So that also brings down that level of fear. And I'm mostly establishing trust and getting clear on her goals. So then the next thing what we do after we've made a plan is we implement. So I went and talked with the anesthesiologist because this epidural is not working at all. We took that out, and I got the patient repositioned. We placed a new epidural, and it worked great. So we brought that down, and now, surprise, surprise, the baby's heart rate's looking better, and we were able to progress in labor. And I think one other thing that I did that was helpful for this patient is get an in-person interpreter for the delivery, since we had like a larger team and possibly NICU coming in. So I had this in-person interpreter, and that ended up being really important because the patient needed to give consent later for using what's called forceps, which are like spoons that help bring the baby down. So that ended up being helpful. But this story has a happy ending. We were able to give her a really low intervention delivery, which I think is what she wanted. That's what's consistent with her delivery she had in El Salvador, right? She had it at home, no, pain medications. She just delivered on her own. So we were able to give, have her have a vaginal delivery. We ended up not needing the forceps, and our pain was controlled. So I think we were able to meet her goals for that delivery. Ended up much better than we were worried about. So any questions about that case study?
Well, I'm kind of curious. So do you normally go through that pattern of assess, diagnose, plan, implement each time?
Yes, that is pretty much the nursing. That's the nursing plan of attack right there. So yeah, when you walk in a room, even say you've heard and report that this delivery went great, really low intervention, this person lost very little blood, and you think everything's going great, and you walk in the room and you see something else. You see frustration, or you see like anger, or mom is losing it. Like maybe like, whoa, right? You're not going to come in like, oh, right, you had a great delivery. Like, I don't know that she had a great delivery. I think she did because I heard that in report, but maybe she thought her delivery went terribly because she didn't feel she was in control. It was really scary for her, or maybe she wanted an epidural and she didn't get one in time. And so she had to deliver without any medication, which was really hard for her. So, and she may be in the middle of processing a delivery that didn't go as she wanted. So assessing is number one when you walk in the door.
And then we have another question. Does a mom's stress level affect the baby?
So I think what's important with stress is that if mom's heart rate's going up, baby's heart rate is going up. The stress hormones like cortisol that we have running through our body is also, baby's sharing off of the very same blood. So that's, if mom is amped, baby's amped too, a little bit. So it's not harmful per se, but it's not great. That's not ideal. And depending on what's going on, if there's other factors assessing the baby, that might, that just may make everything worse. One thing that can happen with stress is that it can make the body, the body only wants to deliver in a place that is safe. Say back in the day, you're, in the forest and you're about to deliver. If you hear a tiger growling in the forest, you're going to clamp up, right? And look for safety, and definitely not have a baby right here in the middle of forest with a tiger, right? So, so our bodies do the very same thing. We deliver when it feels private, calm, safe. So if a woman is stressed, then her labor may stall, things just take longer, muscles don't release and allow the baby to come down as easily. So just, and that's completely apart from the mother's experience of this sucks, like I'm stressed. Like that's not a, delivery anybody enjoys.
Yeah, and then there was one more. How does epidural work?
So an epidural is placed by the anesthesiologist, and it also could be a certified nurse anesthetist, which is a nurse who goes through more years of schooling to become an anesthesiologist, to do the work of an anesthesiologist. And it is where they insert a needle and and then over that, a plastic catheter, take out the needle into the spine. to deliver medication that numbs a woman from the abdomen down. And the woman can still feel pressure. She can feel when it's time to push, and she can get feedback from her body when she is pushing, but the pain element is gone. It's a good epidural.
Okay, I think that was all for the questions.
Okay, so we'll move on to the next slide. So I think we talked a little bit about why this is a good fit for me. I think just generally for nurses throughout the field, you know, if you like a lot of adrenaline and taking all sorts, absolutely everything, then the emergency room is your place. If you are more into teaching or a specific type of medical field like cancer care or surgery, then medical surgical nursing is for you. In my particular case with mother baby, I'm really enjoying helping young families just as they're starting out. I think this is a great way to be involved in public health in the US, is helping women help their families. So the education part is really huge in postpartum. And then there's a little bit of adrenaline and all sorts of stuff that's coming into labor and delivery. So that's what makes it a good fit for me. We could talk about the future of nursing and what's happening if people are interested in that. So I think with COVID, there's been a lot of eyes certainly on the nursing practice. And while COVID has changed, you know, how we're entering work, we're wearing masks all the time now, as are the patients, to help prevent spread of COVID. But other than that, people still got to give birth, whether there's a pandemic on or not. So we're there, and there's a lot of need. I think COVID has certainly shown how many people have been living with chronic health conditions and not necessarily getting preventative care. So we may be seeing moms who have gotten kind of sicker as before they became pregnant, who developed diabetes or hypertension, which is high blood pressure, before even becoming pregnant. So there's certainly a lot of need. At OHSU, my hospital, Oregon Health Sciences University, there's a lot of need for nurses. We're hiring like crazy. So there's definitely plenty of jobs in the field in Oregon in general. Of course, everything from the rural areas and the coast to the city center, everybody's looking for work. This is different than when I graduated in 2009. There was no new job. There were no jobs for new nurses in Portland, California. I think Texas was closed. I mean, it was a recession. So everybody who was going to leave nursing just stayed. And so there just wasn't jobs. So in contrast, there's huge need right now. Everybody wants nurses. And so it's pretty easy to get a job at this point. And that's same is true in all US. So that makes it great for you because, you know, whatever, if you want to go into pediatrics, which is often a hard place to get a job initially, or sometimes L&D is hard to get a job. You have to do med surg first before you go into a specialty like this. But now we're just hiring direct new nurses into our field. So it's a good time to get involved. And so I also wanted to add that you can travel with nursing because your skills are wanted everywhere across the world. Even you could take a travel assignment in Hawaii. I just want to bring up that possibility because you're not limited in nursing. You're needed everywhere, even in Hawaii. So we could move on to advice, but I kind of want to go back to any of those questions that people had about labor and delivery, maybe before we move on.
Yeah, okay. So one student says, you mentioned you wanted to travel or get international experience. What was the process, or was that process easy to navigate? Do you recommend being a traveling nurse if you want to travel?
Yeah, so my study buddy in nursing school ended up doing this program called Nuestros Pequeños Hermanos. Our Little Brothers and Sisters, which is a chain of permanent homes for kids across Latin America. It has about 9 homes. And she had done it in Honduras, which happens to have a surgery center and clinic that's attached to the permanent home. So if you work there, then especially as a nurse, you do primary care during the day for the community at large. People take buses for hours sometimes to get to this clinic, and you're, giving IV antibiotics, intramuscular antibiotics, teaching about blood pressure, teaching about diabetes is mostly what you're doing there. So when I talked to her about this, it sounded like so much fun, and so many other international jobs, they make you pay to work. I mean, like, you have to fundraise quite a lot before you can join. And in contrast, NPH pays you $100 a month to live there, and then they give you a place to live and they give you food. So the $100 is basically for, your expenses of travel and grocery shopping. So it was awesome because I could, I didn't have to worry about, not only not making money for a year, but I could, I was going to be paid a little bit to get by. So that was excellent. It seemed like a really good program. And then there was an application process similar to any other program. I got in. So this is year 2013 to 2014. And I have a little bit of a slideshow video from there that we could watch 2 minutes of at the end if you're interested. Other ways to travel certainly is travel nursing. I recommend getting some years of nursing under your belt before you start your first traveling assignment. So often working a good old med surg floor, learning how to put in IVs, learning how to put in, different tubes into people's bodies that people need, and learning about medications, and just getting those first couple of years of experience under your belt is really good before you take a travel assignment where you'll be seeing how another hospital does things. At least you can lean on your experience that you've already had. But yeah, travel nursing is a great way to see lots of parts of the country.
So for your current job, how long are shifts usually, and what are the hours like?
So typically in the hospital, we work 12-hour shifts. So I come on at 7 a.m. and leave at 7:30 p.m. Night shift starts up at 7 p.m. and goes until 7:30 a.m. There's a few in the emergency room and labor and delivery. There's a few shifts that go from like 11 a.m. to 11 p.m. or 3 to 3 or different things. There's a few people who work 8-hour shifts and just work extra days. So if I work 12 hours a day, someone somewhere in nursing said 36 hours for the week is good enough. We'll call that full time. So we don't have to pick up an extra 8-hour shift every 2 weeks to make the exact 40-hour work week. We just work 3 12-hour shifts per week, so 3 days a week, and then we have 4 days off. And I have a self-schedule, kind of rotating schedule. I work some weekends, some weekdays, but it's great because I have this balance of days and days where I'm totally working, totally focused, and then days where I'm totally off.
Do you have the authority to kick out unwanted people that stress the mom during labor?
I wouldn't say it's like a single person decision. If it's a safety issue, you can get public, officers involved if it was actually like something threatening that was happening. But, my job is really just to advocate for the mom. So sometimes moms give me code words that they want me to come and escort family members out. I haven't had to use any of these skills since with the pandemic, we only have 2 people allowed in the afterbirth time and only one of them at a time. So the mom has already decided who it is that is the most important people she wants at the bedside. So I haven't been faced with this issue in years now. But there used to be like, sometimes a patient would tell me that they have an overbearing mother-in-law who's going to be in the room and they just really want to sleep when they want to sleep. So when they call and ask for chocolate milk, which we do not have on the floor, I know to come in and be like, visiting hours are over. It was so nice of you to come. So like sometimes we work out some code words, me and the patient. Other questions?
Okay. And then this one's a little bit more on the sadder side.
Mm.
But how often are there stillborns? And are there complications that cause that, or does it just happen?
Great question. So definitely, you know, not all pregnancies lead to babies is the reality. I don't have the statistics off the top of my head, but certainly things happen. There, genetic malformations can cause stillbirths or a miscarriage early in pregnancy. But you know, in labor and delivery, we think, oh yeah, you're delivering live babies all the time. But especially at OHSU, because we have high risk moms, we often get people who the baby has passed away inside before they came to the hospital. And now they have the very unhappy task of delivering their baby who's passed. So, and the same labor and deliveries who deliver the live babies are the same ones who are accompanying when it's a sad situation. So, and it's a very similar labor process that they go through as well. So sometimes there's things that we can point to. Man, methamphetamine is not good. Like I could say there's drug you don't do this one. Methamphetamine causes the bloodstream to like have really high increases of blood pressure and is just really bad for the placenta. And so people who have addictions to methamphetamine often lose their babies because the placenta can't take it. And then the blood situation, the relationship between the placenta and the umbilical cord and the baby is lost. And so that's how they lose their babies. That's really sad. Because I mean, even if you're addicted, does not mean that you love your baby less. You have an addiction that is preventing you from the mom you want to be. And most of the time, unless my patients who have an addiction are really out of it from the methamphetamine or withdrawal, they know what's going on and they're really sad. They love their babies too. So, you know, it's just a really, really hard situation. And so meeting people where they're at is really important. So sometimes there's things that you can point to, and yeah, whether or not it was the mom's fault for using methamphetamine, or if it's a completely like, I have no idea, I did everything right and my baby still passed. You know, that's part of the mystery, right? We don't understand. Sometimes we do genetics and autopsy to give people closure and to know, you know, for next time, maybe they can do better. They can do more genetic testing next time and have a little bit more reassurance. But the reality is we just don't know a lot of the time why it happened.
Mm-hmm. How does one specialize as a nurse or specialize in a specific field?
Yeah, so when I graduated nursing school, I was really into pediatrics, actually. And so my last 6 months of nursing school was focused in the area of pediatrics. So I did all of my hours there. So I specialized graduated focusing on pediatrics. Didn't mean that I was ready to be a pediatric nurse, but that was the area I was most looking at. And then when I graduated, there were no jobs in pediatrics, but I had really enjoyed pediatric cancer care. So I figured I'll just go to adult cancer care, and there were jobs in that. And then I believe that ended up being a much better match for me. But you specialize when you walk in the door for your first job. So what we say is that nursing school is the tip of the iceberg. The nursing school tries to teach you, what does heart failure look like? What does what does asthma look like and how do we treat asthma attacks? Some very basic things. And that's how you leave nursing school. And then you get into your area of study, whether that's cancer care, labor and delivery, emergency room. And then your coworkers, the nurses with more experience, teach you much more specifically what's going on and what are the policies, what are the medications that you use in your specific field. So you don't have to learn what all the medications are, but you learn what are the medications you see most often in your specialty field.
Is it easy or difficult to change specialties after?
I think this is an advantage of nursing compared to being a physician. If you're a physician, you specialize and then you're in it. I don't think you often change. It's just, that's years and years of specializing. For nursing, if you get into something and it's not a good fit for you, you can move to another field. So, you know, I started in cancer care and loved it, loved it, loved it. I mean, I still love it for 7 years. And then it just wasn't a good, healthy place for me to continue to stay. I just had so many sad stories filling my head. It was time to try something new. And so I just applied to an opening in mother baby that was in my same hospital and started training. I had 8 weeks of training once I moved to the new specialty. And it took me a year and a half to feel comfortable. And I would still say I'm competent in my field. Once you get even more years, you become an expert. But I'm not there yet. I've only been in mother baby for 4 years, and there's many more classes, much more continuing education for me to learn. Plus, things are changing so much in the field that there's always, you know, new techniques in breastfeeding, new techniques in labor and delivery to learn. And in labor and delivery, especially, I would say there's always somebody's presenting something new to you all the time. A new set of a new history, a new type of patient. The day is never the same twice.
Okay. And then, so how do you deal with baby patient loss?
I'd say talking to my coworkers is an important part of processing it. And, you know, my family members, people who are close to me, making sure that you're getting your needs met, and then that sort of for me, am I continuing to exercise, eat well, sleep well, you know, prioritizing my self-care so that I can keep giving, right? You cannot give from an empty cup. So continuing to fill the cup. I would say a lot of nurses ask, I saw something traumatic happen. I can't get beyond how traumatic. That was so horrible for that patient. And now I'm traumatized vicariously from them. And I don't know what to do with my upset feelings. And reminding them that this patient also moved past that moment. And while we're kind of stuck with this one slice, this one day in the life of this person, that person continued to move on. And sometimes, sometimes knowing that they got to postpartum and they got, you know, they felt better, at least the pain was resolved or something. Sometimes that makes a nurse feel better. But remembering that they went on living their life, and maybe they got therapy, maybe they, even though it was a terrible thing that happened, they felt really supported by the nursing and medical team, and that helped soften the blow. And then maybe later down the line, they are able to have another child. Sometimes we call those rainbow babies, the first baby after a miscarriage or a stillbirth. And so there's hope left that we just don't see because we only see this one day. So remembering that there's more to their story than what we particularly saw. So just sort of helping to do your own self-care process. Many of us have therapists that we talk to, because when you're in a giving profession, you have to be able to fill yourself back up so you can keep giving.
Yeah, definitely. I think that was all the questions so far.
Okay. I see we're kind of coming in on the ending with time. I have just a couple slides left. As far as what to do in high school, I realize that y'all don't have communications classes specifically, but if you did, that would be great. Like how to resolve conflicts in when two people disagree. That's and working on your communication skills is really important. If you can take a language, take a language. That is so helpful in nursing when you can get on people's level. And, you know, I like to say you can't teach caring. When you guys talked about noticing the girl with her crossed arms and what you would do to help her, that's coming from your soul. That's coming from you. And I can't teach people how to care about another human being, but I can definitely teach you how to study for an anatomy and physiology. So I would say if this kind of work reverberates with you and feels like, ooh, that feels right, you know, don't worry about like the amount of studying that's involved with nursing, because we can teach you how to study. It's kind of a game, right? With the professor has a way of teaching a course, whether it's off the book or whether it's off their, you know, how they give their lectures. And then you learn how to take notes that help you pass this test, right? Like that's a skill, and that's a skill you're developing in high school now, is how to learn the way that different teachers teach. Whatever it is, whether it's chemistry, anatomy and physiology, any of these courses is learning how to absorb the material and pass these classes so that you can get to a job that's going to make you happy and be the best uses of your caring. So I would say that's a good thing to take away from high school, is learning how to be a good studier and enjoy your classes that you have. As far as these other couple things, taking at least one AP or college credit course. What nobody told me that I discovered in college was that the one AP class I randomly took in high school had given me a college credit that meant that I could pick classes ahead of the entire freshman class. And that made a huge difference with getting the teachers I wanted, the classes that I wanted, so that I could get through nursing school as efficiently and quickly as possible, and that I wouldn't need to be delayed or take an extra semester of college because I couldn't access the classes I needed to graduate. So even if it's sort of a summer course that you're taking just one college credit, or there happens to be AP classes at your school, that can give you a leg up with accessing classes. It may not be important at your particular, whatever college you choose, but it happened to be helpful for mine. And then as far as the ADN versus BSN track, so that means associate's degree nursing versus bachelor's degree nursing. And associate's degree is a 2-year program, bachelor's degree is a 3-year program. And the thing is that the associates has 2 years of prerequisites, and the bachelor's program has 1 year of prerequisite. So they both equal 4 years. So I guess while you can get to nursing both ways, and there's certainly advantages financially on one side versus the other, but I would recommend considering if you can get into a bachelor's course, there's often financial help and scholarships, even for 4-year colleges, that can make a 4-year college the same price as going through it via the community college associate's degree route, because often the associate's degree, there's delays, that 2 years of prerequisites can turn into 3 years. You got to get, there's sort of some hurdles. So, and in Portland, they're pretty much only hiring bachelor's degrees. So if being in a specific city or working city versus rural is important to you. Just seeing if there's any way you can just go through and get all the education done at once is a good option. If you're doing the associate's degree, that's also totally fine. And I have had friends who have done their associate's degree, get into nursing, and then while they're working, they can take that last handful of courses to get their bachelor's degree. And then that way they can get into management, or they can move to another city where they, can have the lifestyle that they want with their bachelor's degree. And then as far as jobs you could do now, certainly babysitting and childcare helps you to see what's normal, right? What is a normal child's babies? What is a normal baby like? So that when you get in the hospital and you see what's abnormal, then you know. So just some ideas, but not too many requirements there. Right, that's actually all of my time. I do happen to have 2 minutes of that video from Honduras if you want to see it, or we can totally end things here and or do more questions.
Well, students, if you guys want to see the video, just put it in the chat. But for now, there is one question while we wait for those answers. Do you recommend a university/college with a direct admit nursing program as a freshman, or versus having to apply to a program as an upperclassman?
Let's see, can you clarify a little bit more as an upperclassman or freshman? Because when I was in high school, you applied for colleges like spring of junior year or fall of senior year. But
so I think what they're trying to say is, should you apply to the nursing program when you apply for the school, or should you apply for the school, do 1 year, and then apply for the nursing program?
Totally get it. Okay, so for my 4-year bachelor's degree program, which happened to be Pacific Lutheran University, I did really enjoy that college. If you're interested in which one is a good one, I really like that one. The first year, you don't have to say what major you're going into at all. You just start the prerequisites for the nursing program. So you're not applying specifically to the nursing program. You just start taking the courses. And based on your grades and how well you do, for us anyway, there was a fall semester and a spring semester of nursing school that you could get into, a total of 80 spots. And depending on how well you did in the courses and the essays that you submitted for nursing school, they picked like the first 40 students and then the second 40 students. And I think, gosh, was there at that time 500 applicants a year for nursing school? I don't know. But if you go to the school for the 4-year degree, they give you preference. So that's pretty cool. So yeah, originally you don't need to apply. So even if you're curious about it, but not sure, you can start with the prerequisites and just see how you do with the classes. There were some people after they got into nursing school who, after starting some of the courses that were more hands-on, getting on the floor, seeing what it's like to take care of people, they thought, oh, actually, not what I want to do, not a fit. But the nice thing about nursing school is, once you're into the nursing program, within 2 months of taking the nursing program, you're ready to sit for the test to become a certified nursing assistant. And then you can get right into the hospital or into home health care. And then you're already doing a type of nursing, the most basic, which is also to say that is the foundation of nursing, is hands-on, taking care of people, helping them to feel better, even if that's just cleaning them up, right? That's helping them to feel better, and an incredibly important part of our work. So you can sort of get more of an idea, do I want to keep on this track within a couple of months of getting into the nursing program.
Okay, I think we're just going to do questions because I think that's what students are curious about. So we have one student. Can you do 4 years of undergrad and then decide to do nursing? How would that work? I'm assuming they're going to do 4 years or just a different major.
Yes, a lot of people, there are certainly people who do that, who get majors in other areas. and then they apply for a nursing program called an accelerated baccalaureate. So OHSU has a program like that. I think it's 18 months of nursing school, and they take people who have already got a 4-year degree under their belt, whether it's in English or biology or whatever it is, and then they turn them into nurses in 18 months, and it is fast. Fast and intense, but they get them there, and just like every other nurse, they learn on the job with all of us. For me, I liked having the 3-year program because I needed a bit more time to kind of wrap my head around the work, and it sort of took me a little bit longer. I'm kind of a thorough person, and I just really needed more time to absorb the nitty-gritty before I felt comfortable. So I liked my program, but also I know I have plenty of friends who've done the accelerated baccalaureate style as well.
Okay, and there's one last question. What is the difference of care when you were in Honduras versus the US in terms of labor and delivery?
Great question. I was not in labor and delivery when I was in Honduras, but I can speak to sort of like the levels of care. It's more so, we're lucky in the US to have a lot of technology to support, investigating every level of people's chronic conditions. But the problem in the United States is that not everybody has equal access to all of that technology and all those specialists and docs and specialized nursing care, all these medications that we have. Some people don't have before, if people don't have at least Medicaid or health insurance, then you don't have access at all. In Honduras, they have access for everybody, but the amount of medical assistance is less. So there's certainly, in this picture, I'm teaching diabetic education day, and all these diabetic patients have access to only 2 medications, glyburide and metformin. And now you see, commercials on TV for insulin and medications for diabetes all the time. And there was not even insulin for these patients because they don't have access to electricity all the time. Where are they going to store refrigerated insulin? So they don't have access to insulin. So it's more like, okay, I've got these 2 medications and I can teach them the lifestyle adjustments to be made for their diabetes, but we're just going to try to help them live as long as they can, as long as they can and as well as they can. But but we're not going to be able to get them to as good of control as if I had insulin or other medications that we have in the States. So it was sort of maybe bringing down the expectations, but how can I do as best as I can with the medications I have and the medical care I have?
Okay, well, I think that was all the questions. Well, thank you for joining us today and speaking with the students. I know they learned a lot, and definitely a lot of questions that you were able to answer.
Thank you so much for your time. I'm really honored by everybody's presence and coming to the talk. Thank you so much.
Yeah, and then we have a few students. Brooke says, thank you so much. And then I know Liberty High School, they said they needed to leave, but thank you as well. I'm going to go ahead and
students, I look forward to seeing you in the field.